Hey YouTube, That Brady Chick here. This is just a continuation from the part 1 video. So I believe in this video we're going to cover colostomies, drainage colors like sanguineous, serosanguineous, etc. We're going to continue the delegation, etc., etc. A person who just had a stroke a few hours ago cannot be seen by a UAP, not even an LPN either. Like, they are just deemed as unstable and they need to be seen by the RN. The RN is actually going to have to feed that patient with myasthenia gravis. Same thing for feeding a patient who just had a stroke and is exhibiting signs of dysphagia. The RN is going to have to take that over. Oh, and another thing, UAPs can handle equipment. So they can bring equipment to the room. For example, like I said earlier, UAPs can bring blood from the blood bank to the unit. That's as far as they can go. The blood is pretty much the equipment that they can bring to the unit, but they just can't administer the blood. Speaking of which, UAPs can't administer any medications at all, not even like medication creams. Under any circumstances, UAPs cannot give medications. They cannot give injections. They can't even give oral/PO meds. They can't do IVs, of course, and they can't even rub medication creams on them. Oh, and also UAPs can remind patients of what the RN already told them to do. For example, for a patient with that 2-day hip arthroplasty, the UAP can remind the patient to do their isometric leg exercises in bed, right? So the isometric leg exercises, the quadricep setting exercises.
The exercise that I'm demonstrating are called quad sets. They are for both hip and knee replacements. Start with your legs stretched out. Tighten your thigh muscles until your knees are completely straight. Hold that contraction for 5 good seconds. 1, 2, 3, 4, 5, then relax.
That's something that the RN is first going to have to come in and instruct the patient to do. And then later on, when the UAP is taking over with the basic needs, the UAP can remind or reinforce, they might say, that teaching. Because UAPs cannot teach, LPNs cannot teach, but both LPNs and UAPs can remind or reinforce. So LPNs can give oral meds. They can give things by mouth, PO. LPNs can give injections, IM, sub-Q, intradermal, but in the NCLEX world, not in the real world, because I know people are going to be like, but I'm an LPN and I can do this in the real world. In the NCLEX world, LPNs typically cannot handle IVs. I've done a lot of question banks, and in every single one of them, it said that LPNs cannot handle IVs. This is just in the NCLEX world. I know the real world is different, but if you're trying to pass the NCLEX, focus on the NCLEX world for now. You'll get to the real world later. Okay. And yes, of course, the LPNs can remind as well or reinforce. LPNs can do whole care, not whole with a W, but whole with an H at the front. They could do whole care. So for example, if a patient has a type of stoma, which is like a hole pretty much in their skin, then the LPN can actually care for that. So if a patient has a colostomy, and registered nurse RN actually explains colostomies very well. I'll probably put the link below. Colostomy deals with the colon, and I'll try to explain it as best as I possibly can. I might have to step back for this. Basically, we have our small intestine in the middle and our large intestine surrounding that, right? All the way down to the sigmoid colon and the rectum. With a colostomy, it's located at any part of the colon. So if the patient has a colostomy, they can have it maybe at the ascending colostomy, transverse colostomy, descending colostomy. You can even have a sigmoid colostomy somewhere down here, and that's as far as it goes, as far as I know. But yeah, so with colostomy care, LPNs can take care of that, but I just wanted to show you the different locations. LPNs can care for the colostomy, but in terms of assessing it, I believe those in-depth assessments are meant for the RN. I don't think it'll ask you this specifically, but if it is asking about what is the priority assessment when it comes to colostomy, the colostomy appears dusky, pale, cyanotic, any of those words, that's a priority, because that pretty much means there's some type of bowel ischemia going on now. Ischemia, I say ischemia. It pretty much means that there's now low oxygenation, low blood flow going to that stoma, which is bad. So this person is going to need fluids, because it means there's some type of low blood flow, some type of hypovolemia going on. So they're going to need fluids. B, they have sanguineous drainage coming out of the colostomy bag 1 hour post-op. It's actually kind of normal just because it's fresh post-op. 1 hour after surgery is not too bad. Now, if it's like 8-9 hours post-op and that drainage is still sanguineous, by the way, sanguineous means like red, bloody. That's like bleeding, like active bleeding. If it's 8 hours, 9 hours post-op and you still see that sanguineous drainage, then that's pretty much a concern at that point. But what you want to see at the 8-9 hour mark is serosanguinous drainage, which is pink. Think of sero as serous, which is like clear fluid, and then sanguineous is bright red. Clear plus red make pink. That's kind of how I see it put together. Serosanguinous is pink. And then C might say they have the serosanguinous fluid after 12 hours, 8 hours, whatever. That's fine. D would say something like the patient is crying because of the new lifestyle change with this colostomy. It's a concern, yes, but it's not the priority, because out of all those options, that one is the psych option, and physical has to trump psych. If you ever have answer choices like that where there's that one psych answer, almost always you want to go for physical over psych. Why? Because the physical is going to kill the patient before the psych does. Like, yes, D is something that needs to be addressed, but that could be done later on, because that really just involves teaching the patient and teaching them how to kind of accept the colostomy life, how to care for it themselves, but that's not going to kill them. Being sad about their colostomy is not going to kill them, versus having that colostomy be pale and cyanotic and dusky. That's going to kill them, because that means low blood flow, which means either they're bleeding out or somehow they just became hypotensive. And that's another thing too, because the colostomy is obviously going to drain out their poop content, like their fecal matter, depending on where the colostomy is located, like whether it's ascending, transverse, descending, etc. Closer that colostomy gets to the sigmoid or towards the rectum, the harder the stool is. So if they have a colostomy in the ascending colon area, then their stool might be watery. If it's at the transverse, then it might just be soft. And then if it's at the descending, because it's closer to the rectum, then it's going to be a little bit harder at that point. If they have a small intestine ostomy, I forgot what those are called. I think it's ileostomy. Yeah, because the ileum is part of the small intestine. So ileostomy would be a small intestine ostomy. There you would see more watery stool, which is actually normal, because like the stool hasn't formed yet if it's at the ileum, because again, the closer you get to the rectum, the harder the stool forms. Because NCLEX will try to trick you and try to make that look like a priority, but no, it's actually normal if the stool is watery away from the rectum. Because remember, the closer that ostomy is to the rectum, the harder the stool. The farther away that ostomy is from the rectum, the more watery the stool. So the farther away from the rectum would be like that ascending area, or even anything in the small intestine, you kind of expect that watery stool. In that case, the answer was the dusky, cyanotic, pale colostomy, because that's a circulation issue. Sorry, that was many different side notes in one. Hopefully you guys were able to grasp that. But yes, LPNs can do ostomy care. I believe they can also do tracheostomy care. We're talking about the NCLEX world here, not the real world. Also, a good thing to know is that LPNs actually can do certain assessments, because I got this one wrong on a question bank once. It was asking which one can the LPN do, and one of the options were, it was a select all that apply, and one of the options were that the LPN can assess lung sounds and bowel sounds. And because it's an assessment, I was like, okay, automatically the RN can do that. But no, LPNs can actually assess lung sounds and bowel sound. Like, I think those are the only two assessments they can do. Keep that in mind. LPNs can do lung sounds and bowel sound assessments. Everything else is for the RN. Also, the LPN can do tube feedings, like NG tube, G tube feedings. They can do that. Again, UAPs don't even touch that stuff, because think of feedings as medication. The UAPs cannot give feedings at all. So again, LPNs can give PO meds, injections, but no IVs in the NCLEX world. Can remind/reinforce, do ostomy care like colostomy care. LPNs can do tube feedings like NG tube and G tube, and LPNs can do certain assessments like lung and bowel sound assessments. Okay, the next one is RNs, us. So RNs can eat. I know you guys have heard that before, only RNs can eat. So that pretty much means only RNs can evaluate, assess, and teach/instruct, right? So RNs are the ones who have to handle the unstable patients. The patients that are now reporting that shortness of breath, for example, reporting that chest tightness, suddenly becoming diaphoretic and can't breathe. That's usually an MI. So if you ever see diaphoresis paired with shortness of breath, think MI. Diaphoresis means sweating, by the way, like profuse sweating. Patients that are within that 24 hours post-op, so those hip replacement patients, bowel resection patients, anyone who's been in surgery within the first 24 hours, the RN has to look over them. Patients who are just about to receive blood transfusions, patients with myasthenia gravis, or patients who just had a stroke, RN. RNs have to be the ones who handle the new admissions. Don't let the NCLEX trick you, because new admissions are not always new admissions. It might say something like the patient has been in surgery for X amount of hours and now the patient returns to the unit. Who takes care of them at this point? Your answer should be the RN. Why? Because any patient that returns back to that unit, and this is something that Nexus Nursing taught me, any patient that returns to that unit is now considered a new admission because they just went off the unit. I don't even care if it's for 5 minutes, 10 minutes, they were off that unit, but now they returned. They require a new and in-depth assessment at that point because anything could have happened during the surgery. So now we have to assess them and make sure there are no changes and that they are stable. So that's why any new admission, so a person being admitted to the hospital, but also a person returning to the unit, has to go straight to the RN for assessment, not the LPN, not the UAP. So for example, this is a tough one that I got on one of my question trainers. So it said, if an RN, LPN, and UAP are working on an orthopedic unit, for example, and the RN has only 3 months experience, while the UAP and LPN each have 5+ years of experience on that unit, the RN is actually the one who has to take on the new admission and or the unstable patients, even though they have the least amount of experience. So it doesn't even matter that they've only been there for 3 months. It's just the mere fact that they're an RN that it's automatically within their scope of practice to take on that new admission, to take on those unstable patients, even though they have the least amount of experience compared to the UAP and LPN. It's just how the NCLEX world works. So next, so this is a very short tip. When in doubt, for any question, especially if it's one of those priority action question, like for example, what would you do next as the nurse? That's a priority action question. Any type of question like that, if you don't know the answer, just go with ADPI. Immediately go with ADPI. That's actually what I did on my NCLEX with some of the questions I got. I didn't know the answer to, and I just went straight to ADPI, and it made sense. And what do I mean by that? The first word of that acronym is assess, right? So if you ever get those priority action questions and it's asking you what you would do next, when in doubt, choose an option that says to assess. And be careful because sometimes these answer choices will not directly say the word assess. It'll actually say words like determine, monitor, check. For example, check the vital signs. That's pretty much assess the vital signs. Monitor the drainage. That's pretty much assess the drainage. Ask the patient about. Asking is also an assessment. It is. So just look out for those words that pretty much equal to the word assess. Next is psych, and I think I might end off the video with this one. So let's start with the big guns, like Simple Nursing calls it. These are the MAOI, the monoamine oxidase inhibitors. So yeah, the names of these MAOIs would be selegiline, phenelzine, tranylcypromine, and isocarboxazid. So notice how they have those suffix "ine," except for isocarboxazid. But one thing you guys should know as well are that I learned this from Mark Klimek reviews actually. All psych drugs cause dry mouth. And we know this already because they already end in "ine." So when you see "ine," I want you to think, okay, there's probably some dry side effects associated. So we're going to look for those dry conditions like dehydration, which then leads to low blood pressure sometimes, constipation, urinary retention, things like that. It won't always have all those side effects, but most likely you'll see dry mouth, right? Because that's one of the not so bad side effects, but it's still a dry side effect. So the main thing to know with MAOIs specifically, and this does not go for any other antidepressant as far as I know, and as far as NCLEX tests you on, MAOIs can lead to hypertensive crisis, right? But that's not the thing you need to know. The thing you really need to know is to avoid tyramine-containing foods if you are taking an MAOI. So if you're taking selegiline, phenelzine, tranylcypromine, isocarboxazid, avoid the tyramine-containing foods. Cheese, wine, beer, processed meats like salami, ham, bologna, sauerkraut, whatever that is, because I've never had that before. But be aware as well that the NCLEX does know that you know what the main tyramine foods are. So yeah, just be aware of answer choices that'll have like fruits and veggies in the options, because I actually received a very interesting question on one of my practice tests that said a patient is on phenelzine, which is an MAOI, and which of the following would you instruct the patient to eat? So pretty much it's asking which of these following food options are safe for the patient to eat while they're taking an MAOI. Again, we're thinking avoid tyramine foods because they're on an MAOI. So obviously the first thing you want to do is eliminate C and D, because beer and cheese, that's obviously tyramine containing. But They were tricky because they knew you would narrow down to A and B because those are fruits and veggies. You don't typically hear about those things containing tyramine. For this one, I honestly had to search it on Google because I'm like, what fruits and veggies are low in tyramine? Because I don't know. No one told me about this. So the answer was actually avocados. Avocados have very, very little tyramine, right? Compared to everything else. So bananas actually are a pretty good source of tyramine. And of course, so is beer, so is the cheese and all those other main tyramine containing foods, but bananas have tyramine in them. So be careful of those questions. I don't know for sure if they'll ask you questions like that, but that's just a question that I received on my practice test. And girl, that was tricky, but I like that they did that because it kind of made me think, oh shoot, like I need to think outside the box because the NCLEX might try to throw something like this at me as well. Be prepared for everything. Trust me, be prepared for everything. So if you are unsure of the fruits and veggies that typically contain tyramine, I would honestly recommend looking it up on YouTube, which I did the day of. And there were a few videos that kind of helped, but a lot of them were kind of just like, what the heck? Do you even know what you're talking about? Sorry. But anyways, Google is your best friend with that too. Just look up fruits and veggies that contain tyramine. Because the whole reason we want to avoid pairing tyramine with the MAOI is because those two paired together leads to hypertensive crisis. So that patient's blood pressure can shoot all the way up to like in the 200s if they take tyramine containing foods with that medication, right? So it's just very, very important that we avoid that because what can that high blood pressure lead to? It can lead to a stroke. It can lead to very, very weak vessels. Because imagine all that high pressure on those little tiny blood vessels. Like that's going to cause bleeding, right? Just imagine that. Oh yeah, I also got another question that said further teaching is needed if the patient on an MAOI like selegiline says, A, I will not stop taking this medication. B, I know this medication is going to take a couple of weeks to work. C, I will go out and celebrate with some pepperoni pizza. Or D, it may be a while until I start to see improvements in my depression. So the wrong statement, aka the statement that requires further teaching, would be C. When the patient says, I will go out and celebrate with some pepperoni pizza, that's wrong. Why? Because pepperoni pizza, first of all, the pepperoni is processed meat. That has tyramine in it. The cheese has tyramine in it too. And even the pizza has yeast. Yeast has a lot of tyramine too. That's probably why like beer is not recommended. So that would be the statement that requires further teaching. That's why we call it the wrong statement, because we actually need to address that really quick. Because if that person thinks that they're going out today to get pepperoni pizza after being on an MAOI, they got another thing coming, okay? Because we're not getting no call about some hypertensive crisis going on at Pizza or Pizza Depot or Pizza Nova. Take your pick, okay? We need to protect our patients at all costs. So that would definitely require further teaching because all the ingredients of the pizza include high tyramine content. By the way, the three types of antidepressants would be SSRIs, SNRIs, MAOIs, and the first two are very related to each other because they both involve serotonin. So you must let the patient know that it will take 2 to 6 weeks or sometimes 4 to 6 weeks for the antidepressant to kick in. Like for the actual depressive symptoms to kind of decrease, it's going to take a few weeks for that to work. So another question that you might see, which I got a lot on my practice test, would be a patient who's on an antidepressant and after 2 days they come in saying that the medication is not working. They need further teaching because they need to be told that it's going to take weeks, not days, to work. So at least 2 weeks, you know? And also another thing that Simple Nursing told me is that typically with any type of drugs that act on the brain, it's going to take weeks to work. So even levodopa carbidopa, which is that Parkinson's medication, right? Can't jump rope if you got no dope. That's what he says. But yeah, so it pretty much gives you dopamine, but that's a neuro medication, which is also going to take weeks to work, even though it's not an antidepressant, but it still works on the brain because it leaves dopamine in the brain. Also with levodopa carbidopa, a good phrase that Simple Nursing taught me about is that you want to leave the protein and carb it up, which means no protein allowed if you're taking levodopa carbidopa. Remember that. Leave the protein and carb it up. Also, when it comes to antidepressant, within the first 2 weeks of taking an antidepressant, we must watch out for signs of suicide because antidepressants can actually give them enough energy to carry out the suicide ideation that they've been having. So you want to look out for statements like, I'm cured, because first of all, that's wrong because it's not going to cure you. It's just going to slow the progression of depression or kind of like mask the depression in a sense, but it's not necessarily going to cure you. Majority of medications do not cure, especially on the NCLEX. So if a patient says I'm cured, it's usually wrong. Or if they say something like, I won't be around much longer, that's kind of indicative that they're going to try to off themselves. I gave away my favorite baseball cards. That is like a hallmark sign of impending suicide. So when a patient gives away things that are actually valuable to them, precious to them, like their favorite anything, think suicide risk, especially if they were on an antidepressant, and especially if they say that within the first 2 weeks of taking that antidepressant. So when it comes to these psych questions, especially when it's mentioning those psych medications, always pay attention to the timeline that the question gives you, right? Because if the question says they've been on the antidepressant for 10 days so far, 10 days is within that 2 weeks. And we know that within the first 2 weeks of antidepressants, we must monitor for suicide ideation. Pay attention to that timeline because they don't tell you for no reason. Trust me. Okay, so some ways to remember SSRIs would be pram. So for example, escitalopram or citalopram. Prams would be SSRIs, but there's also other names like sertraline. Sertraline you can remember because SER, that's the first 3 letters of serotonin. SSRIs, they start with serotonin too. Also SSRIs end in atine, like fluoxetine, paroxetine. SNRIs, they might not even test you about this. I didn't see it in any of my question banks, to be honest, but SNRIs would be like venlafaxine, duloxetine. A rule of thumb for SSRIs, and I think even SNRIs, is to never ever pair St. John's wort with SSRIs because it will lead to serotonin syndrome. But basically serotonin syndrome, the way to remember it is that everything goes up. So the blood pressure, the heart rate, the temperature goes up, the movement, so they'll have like seizures, they'll have tremors, all that stuff. Everything just goes up. So think of it as serotonin itself makes you feel really energetic. That's what SSRIs give you. It gives you more serotonin. But imagine serotonin in excess. So that kind of makes you kind of go into serotonin overload where now you're like hyperactive and everything's just going up and you're like seizing and everything. Not a good situation, right? Big yikes. Those are signs that you want to report, right? When you see that blood pressure shooting up and the heart rate shooting up, that's pretty much serotonin syndrome, especially if the question states that they've been on an SSRI, and they won't tell you it's an SSRI. They'll just give you the name of it, like paroxetine. They've been on paroxetine and now they're like tremoring and their blood pressure is 167 over whatever. You kind of just got to pick up on those cues and put them together and say, maybe it's serotonin syndrome. Another quick tip is that even in psych, physical needs will have to go first. So for example, if a psych patient requires certain needs at this moment and the options are A, stay with the client, B, talk to the client, C, take the client to group, or D, address the client's low BMI, then your answer is D, because D represents a physical issue. It's a physical need. So if there are no physical needs involved in the answer choices, then just go with the answer choice that addresses safety needs. For example, I did a practice question that was like a patient who was escorted into the ED, the emergency department, by cop is disoriented, confused, and restrained, and the priority is A, tell the nurse manager, B, ensure a safe environment, C, do a physical assessment, or D, ask the client what happened. So the answer was actually B. So don't get tricked and choose D. Even though D is technically an assessment, it would never ever make sense to question a confused client, right? All right, we're gonna wrap up this video because my camera just died and I got just a little bit of juice left in it. So yeah, the answer for the last one was B, which was ensure that safe environment for the patient. So a few things you want to focus on for this question is the fact that one, they are restrained. So when a patient is in restraints, you kind of want to think, okay, I need to assess this patient. I need to make sure that circulation is still adequate to the parts that they're restrained at, right? So if they're restrained at the 2-point restraint, which I think is just the 2 wrists, of course you want to assess circulation to the wrist, right? So the way you would do that is you're kind of looking for pallor, cyanosis, duskiness past the point of the restraint. If past the restraint you see paleness, dusky, cyanosis, which is the blue discoloration of that limb, then that is a sign of poor perfusion. So there's not enough blood flow getting to that extremity. So that's a priority to address. Another thing you want to do when a patient is restrained is you don't want them to develop contractures, which is pretty much when like the muscle kind of stiffens in that position. You don't want that to happen, right? So when they are restrained, every so often you have to actually go into their room, loosen one restraint at a time, because if you loosen both, they're just gonna come at you, right? I've never been in that situation, but rule of thumb, do it one at a time. Loosen one restraint at a time, so maybe just the right wrist first, and then you do passive range of motion exercises with that, and then you restrain them again on the right wrist, then you go over to the left wrist, undo that restraint, and then you do passive range of motion with that one too. So the purpose of that is just to prevent contractures at those areas. But in this case, this patient is just being brought to the ED. Yes, they are restrained, and yes, we do have to think about those things. But once we get to the answer choices, we realize that none of them are really focusing on the restraints. They're more so focusing on what's the priority for this patient at this time. When it comes to a lot of psych questions, if you don't really see that answer that's like that airway, breathing, circulation, priority issue answer, then you kind of want to go to safety, because at the end of the day, we are following Maslow's hierarchy of needs, which goes from physical first, which is priority. Then if you don't see any physical, like if you don't see that airway, breathing, circulation, then you go to safety. That's the next one up. That becomes the next priority if the physical is not involved. And in this case, it was tricky because you do see the words physical assessment, then in the same breath, you do see ask the client what happened. But again, that wouldn't make sense because the client's confused. But even if the client wasn't confused, if you see 2 answer options in a 4-answer multiple choice question that are very similar to each other, they cannot be the answer. It can't be, because for one to be the answer, the other has to be the answer. But when it comes to the multiple choice questions, you can only end up with one answer. It's not a select all that apply where you get multiple answer options that you can choose from. No, you have to literally commit to one answer for these kind of questions. So that's why, like, that's one of the things that I picked up on with these 4-point multiple choice. Like, if you see 2 answers that are very similar to each other, you have to just cancel them out, because there's no way, because for one to be the answer, the other has to be the answer, but you're only supposed to choose one answer, so it can't be those. Hopefully that makes sense. In that case, you would be left with tell the manager or ensure a safe environment. So the only time you want to just go up the chain of command, and they call it that because you're going like straight to the commander of your unit, which is your nurse manager. Oh, there goes my battery again. The only time you want to do that is if a patient's safety is at risk, typically because of another employee. For example, I got this question on a question bank. If you're working with a UAP and you both are changing a client and you notice that the UAP has the smell of alcohol on their breath, that's automatically a dangerous situation for the client. And the answer options that I saw were A, continue addressing the client with the UAP and then address the concern with the UAP after. B, confront the UAP about the issue of alcohol on their breath. C, ensure to monitor the UAP for the rest of the shift. Or D, report the UAP to the nurse manager. The answer in this case is D, report the UAP to the nurse manager. Why? Because now the patient is in danger because of another employee, which is the UAP, because they have alcohol on their breath, which means that they were drinking, which means they're not in sound mind to provide safe, appropriate care to patients, right? At that point, because now the patient's life is in danger and other patients' lives are in danger too, we have to go up the chain of command and just report it to the nursing supervisor. The only time you want to dispute it horizontally, which means dispute it to the UAP herself, is if it's a problem between yourself and the UAP, but there's no danger for the client. For example, I got a question on a practice test. I keep declaring that because I don't want you guys to think I'm giving you NCLEX questions, because I'm not. It's just not right. So yeah, this was from a practice test, and it said an RN delegates the ADLs of a particular patient to a UAP. An hour later, the RN comes back to evaluate the situation and realizes that the UAP did not do what the RN had asked them to do. In that particular situation, that's when you can go straight to the UAP and assess what happened. So the way it would probably word it is ask the UAP, or assess the reason as to why the UAP did not follow through with the task, or determine the reason why the UAP didn't follow through with the task. Those are all different ways of saying assess the situation first. Again, that is more of a horizontal situation where you go straight to that coworker versus going up the chain of command to the manager, because it's an issue that's between yourself and UAP. Manager, patients have nothing to do with it in this case, right? You could see it as a safety issue, but technically it's not, because the UAP is of sound mind to do it. It's just that they refused to do it. We just want to assess the situation further. And another reason why that's correct as well is because that also confirms the nursing process, which is ADPI, right? Which is that assessment goes first. Remember, when in doubt with any question that you're unsure of, always assess first. Click on anything that implies that we are assessing first. That's just my tip. All right, guys, I hope that helped. Everything that I've told you came from UWorld, even the UWorld question bank, Simple Nursing, from Registered Nurse RN, Nexus Nursing. If you ever need to confirm anything I've said, you can always refer to those resources. I have all those links for all those different resources under my previous video, the one about how I passed the NGN NCLEX with only 85 questions. These are all based on answers from question banks that I have done, right? I remember the questions and I remember the answers. Just trying to give you guys patterns and tips that you can kind of keep in mind and follow so that by the time you see it on the NCLEX, you kind of know what to look for already. I might have to do a part 2 because there's a lot more I could tell you guys from what I remember. So if you'd like me to do a part 2, let me know below. I might do it anyway because I know everyone's trying to get their NGN done soon, and you should. Stay tuned for that then. Alright guys, thanks again for watching, and always remember, natural hair grows. Don't you forget it.